Hello, I'm Dr. Cliff Robertson, President and CEO of St. Francis Health System. With me today is Michelle Keeling. Michelle is our executive leader for our St. Francis Hospital in Muskogee. And our plan today, or my thought today would be, is it would be beneficial for you to hear some of the insights from one of our leaders in one of our smaller communities. I'm going to start off by just running through some of our statistics like I have in the past week. And Sivan, I don't know if you're able to pull up the slides here. I just will walk you through what has been posted on our website this week. If you want to scroll down, Sivan, and go to the first slide. So here is our trend of our inpatient COVID positive patients. As you will see, we were at 270 today, and we have been in that 265 to 285 range now for almost 10 days, 2 weeks. Sivan, if you go to the next slide. This is a graphic that just shows year over year through the summer and how different 2021 has been, the summer of 2021 has been than the summer of 2020. I will point out that last summer we did see a little bit of an increase, but then it plateaued fairly quickly, and we never were above 100 patients. This year, which is the red line, obviously you know that we're up near 300 patients as of today. Next slide, Sivan. One other slide we've added for your information. The red line shows COVID-19 2021 patients that are requiring ventilators in the St. Francis Health System compared to our experience in January of 2021, when we were in the middle of our last surge. This is different, obviously, and it's something that we're paying obviously very close attention to, because these patients that require mechanical ventilation are obviously sicker and tend to be in the hospital for a longer period of time. And then lastly, this is the data that has been updated on our webpage. As I said, 270 patients. There's 207 of them that are in isolation, which for the lay people, what you should understand is that means that they're still contagious, and those patients we have to treat differently than the 63 patients that are no longer contagious and are no longer in strict isolation. Our average age continues to be much lower than what we experienced back in January. The number of patients that we have requiring a ventilator across all of our hospitals today was 77, and notice the average age of patients requiring a ventilator is young. It's 55. It's substantially younger than we've seen in the past. So before I introduce or turn it over to Michelle, who I already introduced, I just wanted to say a couple of things. One of which is, again, the things we're focused on are the health and well-being of our staff. As we've talked about before, staffing is much more of a challenge this go around than it was the last time we had a significant surge. And so we are spending a lot of time focusing on our staffing issues. I'd also speak to the fact that some folks have raised concerns about ICU capability or ICU capacity. What I would tell you all and tell the general public is that we will always have the ability to care for somebody who's critically ill, who shows up in one of our hospitals and needs to be taken care of. While we have a set number of ICU rooms and ICU beds, we do have capacity to expand should we need to into areas that would be less traditional. I think I've mentioned on prior calls, if we needed to, we could expand into our recovery room areas where we have the capability to handle ICU level care in our pre and post surgery areas. We could actually even use operating rooms as ICU rooms if we needed, because we have all of the gases and equipment that we would need. And so, thankfully, we've not reached that point, nor do we predict we will reach that point, but I just wanted to make it clear to all of you that we do have the ability in less traditional ways, but the ability to expand our ICU capabilities, should that be required. I'll stop there, and we'll turn it over to Michelle for a few minutes, and then we'll take your questions. Michelle?
Hi, good afternoon. Thank you, Dr. Robertson, and everyone who's on the call today for giving us the opportunity to share some information from Muskogee and from a community hospital in the region. Statistically, today we have 53 positive inpatients, and in terms of a percentage, that represents 47% of our medical surgical admissions. So a high percentage of our patients we're caring for today are COVID. In terms of our critical care, as Dr. Robertson mentioned, 12 of our 19 critical care patients are COVID, or 63%. We have 2 other units taking care of COVID patients. That's the progressive care unit, which is a step-down unit from the ICU, and then our 3rd floor medical surgical unit. This morning we expanded to another unit because of the number of positive patients we have. This does represent the highest number of patients we've had since the surge in January. At that time in Muskogee, we had 72 positive inpatients. Some of the questions that we're often asked is, what is the COVID impact on a smaller community and a smaller health system? So as Cliff mentioned, staffing is exceedingly difficult at hospitals of all sizes across the country, but it is extreme in the rural hospital and smaller communities. Our overtime rates are at an all-time high, particularly for our clinical staff, nurses, doctors, laboratory technicians, but also for our managers and leaders who have stepped in to work night shifts and also on the weekend. Having a smaller team means you have a shorter bench than some large hospitals. An example, our manager of respiratory therapy, I visited with him this morning, and he has worked 42 straight days because he's helping cover the respiratory therapy department on the weekends. Our ER, like all ERs, are challenged, but also, as Cliff said, we're able to flex up to accommodate the surge, and it does translate into taking care of patients in areas that we might not typically. Also, similar to the urban areas, we have seen a younger age population. Our first patients last summer that we saw coming to the Muskogee ER were members of a quilting group. So the average age in that group was between 65 and 75, and it's much different today. We're seeing patients in their 20s, 30s, 40s, and also pregnant patients as well. So being in a smaller hospital, a small, close-knit city, the likelihood of knowing a patient, knowing their family, or knowing a loved one is intensified. So care is very personal in a smaller hospital. So our staff's physical exhaustion is coupled with emotional exhaustion, knowing a lot of these patients firsthand. The importance of being in a system as a small community hospital really cannot be overstated. Having access to expertise and resources within the state of Oklahoma is one of the key reasons that we've been able to successfully meet the surge. We have a daily command center with the leaders at our headquarters in Tulsa. We were able to have the equipment to test for COVID locally, which gives us quicker results and enables us to address the patients with the COVID sooner. The turnaround time for supplies is greatly shortened by being part of a health system. And as Dr. Robertson mentioned, our utilization of ventilation and ventilators is much higher this year. And luckily, being part of the system, we've been able to have access to ventilators and also through the emergency management resources from the state. That also brought us access to vaccines as soon as the larger cities did. And then an important treatment option was the monoclonal antibodies that we're able to offer outpatients here in Muskogee in the eastern part of the state. And just as early as last Friday, the system was able to provide the medication to help us take care of those positive patients that were part of the Muskogee County Jail. So being part of the system helps us translate those benefits to our local community. And I'll be happy to answer any questions.
Thank you, Michelle. We can turn it over to questions from our media partners.
Do we know how many school-age children, those who are under the age of 18, are currently in your hospital system, or a percentage?
I can answer part of that question. I don't know the specific number for folks under the age of 18. What I can tell you today in our children's hospital at our Yale campus, there were 6 children admitted that are admitted for COVID, have COVID, and are sick enough to be in the hospital. As I think you've heard, that number is relatively stable over the last few weeks. I think we've been as high as 10, and we're back down to 6 currently. I think Lauren would be able to provide you the numbers of the percentage of our COVID patients that are under the age of 18 currently, because we do look at that stat.
Yes, I can get back with you with that information. Is that Elizabeth? I didn't catch who was asking that question.
It's Abigail Dye with Fox 23.
Awesome. Okay, thank you, Abigail. Next question.
Hi, this is Corey with the.
Go
Oh, thank you. Sorry, this is Corey with the Tulsa World. Appreciate y'all doing this. When we spoke a few weeks back, you talked about how St. Francis at the main hospital in Tulsa was about to flip the switch on a 6th COVID unit. I'm wondering if that ever happened and if you're able to keep it at 6 COVID wards, or if you've had to do more or that type of thing.
So yes, the answer is yes. There was a 6th unit that was created, and to my knowledge, we've stopped at that point. We have 6 dedicated COVID units. If you go back and look at the graphic, we've been relatively flat across our system for the last almost 10 days. There are always, one day we'll be up a few patients, the next day we may be down a few patients. But the number of inpatients, particularly at the Yale campus, has been steady and has declined a little bit from a couple of weeks ago. That does not mean that we're at the peak. I know people are always quick to say, well, good, then that means it's behind us. What we've seen with this virus is we can have these little plateaus for a week or two, and then we'll see another upward trend in terms of the number of infections, which then thereby leads to an increased number of admissions. So we don't believe we're out of the woods yet, although we do believe it is at least a positive sign that the number of patients that are being admitted has been stable. One last thing, response is, at the end of the day, what really matters is the test positivity rate. And that obviously stays high or has stayed high in our region. And so consequently, we need to not let our guard down, because we're not out of the woods by any means.
Thank you. And just to clarify one part about that, Corey, of the cohort units, that does not represent the total number of beds that are being occupied by COVID patients, because they are spread out in other areas of the hospital where there are negative pressure rooms to keep them in isolation. So on the website, on our data dashboard, you can see that we have those that are in isolation and those that are out of isolation, so that those numbers will speak to the total impact that we're seeing in the hospital in terms of patient census.
Thanks, Lauren. Other questions?
Yeah, I have a question. This is Elizabeth from Public Radio Tulsa. Thanks for taking the time. I'm curious, you said that you are working on staffing. Can you say some concrete things that you're doing to improve staffing?
Well, so a couple of things. We, like pretty much every health system in the country right now, have orders out for traveling nurses. We've filled some of those orders, but have many more orders outstanding that as of yet aren't filled. One of the ways we've been also creating extra staffing capacity is through offering incentives to our own staff to be able to pick up extra work, extra shifts. That is a short-term solution. We know that because you can only have ask folks to do so much before then they just begin to become excessively fatigued and or burned out. We're also actively recruiting. The nursing staff and our other clinical staff, those shortages have been around before the pandemic and are projected to continue for years. And so, the real solution for us is the creation of more interest for nurses and others to work at the St. Francis Health System, and then for us also to focus on retaining the staff that we have today. One last comment I'll make, there's a lot written, at least in the healthcare industry literature, about the number of staff that are leaving their jobs or full-time jobs to go take these traveling nurse opportunities as one example, but it's not just nurses, it's other skilled professionals. And so, we're also focused on retaining our existing staff because they are so important to us and to the community.
Thanks. And just a quick follow-up on that. So you're actively recruiting. Have you thought about shifting staff that's doing outpatient procedures to help these nurses who are, terribly burnt out and saying that they have PTSD, et cetera?
Yeah. So the issue of, delaying scheduled surgeries has come up. And what I will tell you that is different in 2021 than the way we might have approached things in 2020 is what we went through in 2020, where we restricted surgical care and only did, the utmost of emergencies. We thought that would create a significant extra capacity, both from a staffing perspective, but also just in terms of being able to handle the COVID patients in the hospitals. What we learned in retrospect is it really doesn't create a bunch of extra capacity. What I think I shared a couple of weeks ago, or maybe last week, what we're doing on a day-by-day basis is reviewing our schedules, our surgical and our procedure schedules, trying to determine if there are two things we can do. One of which is, if we were to delay a case, would that be safe and acceptable from the patient perspective, but would it also free up staff or other capacity, supplies, et cetera, that could be used or that is needed for COVID patients? And so while we've made some decisions to delay a few things, what we've, and we're doing this on a day-by-day basis, what we've really learned through the last 18 months is that tactic doesn't actually deliver as much capacity as one might think. The downside when you do that is that, we delayed a lot of care a year ago, and, unfortunately there may have been some negative repercussions for patients as a result of that delayed care. And that isn't something that we want to do this go around if we can all at all help it.
Okay, thank you.
Thank you. One other question that's come up that I'll just answer even without you asking is St. Francis Health System does support masking, and we would, if the city council or if the state implemented a mask mandate, we would be in support of that. We know that there are just a handful of tools that all of us have today to protect ourselves and our family, and wearing a mask is one of those. I would just reiterate, as a physician, we know that one of the issues with this virus is such a great percentage of folks can carry this virus and be asymptomatic or minimally symptomatic, and that's where the value of the masks really comes to play, is to help decrease the chance that somebody that doesn't know they have COVID spreads COVID to somebody that obviously is at risk for it. So we would be supportive and are supportive of masking, but we're also supportive of hand washing, social distancing, and the vaccine as well. We believe all four tools are important to be used to help protect ourselves and our families.
Thank you.
Hey, do you mind if I step in with another question, Corey with the Tulsa World here?
Go ahead, Corey.
Thank you, appreciate it. I'm sorry, my internet keeps dropping out, so I apologize if someone has already asked this, but I know earlier you referenced, St. Francis has the ability to step up ICU care in non-traditional ways, like in operating rooms, that kind of deal. When you talk about your actual normal ICU capacity, would you be able to speak to or describe or characterize maybe how often there's a wait to get an ICU bed, or maybe there's not yet a wait for an ICU bed? I'm just curious if you might be able to kind of shed any more light on that.
Yeah, I'll speak in generalities, and then maybe Michelle can also speak to it specifically from a smaller community, a hospital in a smaller community's perspective. The general public doesn't understand that hospitals are always managing the balance between the number of patients that are needing an ICU bed versus the capacity, the number of ICU beds that are available. We very rarely, across St. Francis, but I would also speak across the entire industry, hospital industry, we very rarely have unused ICU beds. That the nature of how we care for folks is that our leadership, our nursing leadership, our hospital leadership, Michelle is one of those examples, are constantly managing the demand versus the capacity on a daily basis. So what I think folks have come to believe is that we have, outside of COVID, we would have 50, 60, 100 ICU beds staffed and sitting empty. That's not the case. It is not uncommon for us, even outside of a pandemic, to have patients who show up in our emergency department that are sick enough to require an ICU level of care and have to be cared for in the emergency department for a few hours until a patient is discharged out of an ICU bed, and that they can, be then subsequently be moved into. So that's a normal state of affairs for us, and it's a normal state of affairs for just about every hospital in the United States. Before I let Michelle answer, I'll answer. The other thing is, in all of our surge plans, as we a year ago started preparing, and even before the pandemic, preparing for what would we do in a mass casualty event? How could we absorb 300 ICU patients as a result of a tornado or some other catastrophe? Every hospital in this country has the ability to use its facilities different than it might use them in a steady state. And the example of ORs, we would never think about using an OR firsthand as an ICU, but anesthesia machines are ventilators, and they can be used as a ventilator if we needed to do that. Obviously, that wouldn't be ideal, but it would be safe and effective care, and it would be appropriate in a given situation where we had more demand than we had we had capacity in our traditional ICU rooms. So I just want to share that with you all, because I also don't want the general public to worry that they're going to, be in a car accident and then not be able to be cared for. That isn't the case. That isn't going to happen. But it is also true that given the demand of the number of sick patients with COVID that we've had that have been very sick, that it is more challenging for our teammates like Michelle to, on a day-to-day basis, manage the demand versus capacity equation that they have to manage. Now I'll stop for a second and let Michelle speak to it specifically from the Muskogee perspective.
So I would like to echo Dr. Robertson's comments about the daily management of critical patients in our hospital. So prior to COVID, we were between 90 and 95% capacity in our critical care. And since COVID, I'd say we're closer to 100%, but back to the ability to transfer patients and be part of a larger health system. So within the St. Francis Health System, they can look across all of the hospitals and prioritize those patients that have the greatest need for critical care. And then outside of the St. Francis Health System, we're able to collaborate with other hospitals, not within our health system, but luckily their capacity will wax and wane with ours, so that maybe we're at 100% capacity, but they may not be, which I think speaks to the importance of this pandemic being one of collaboration and communication. So we do get creative. We have a large hospital, and we can take care of patients in areas that we don't always, like Dr. Robertson said, it may not be our typical, but we're able to for a short amount of time until we can find another setting that might be more appropriate for that patient.
Thank you, Michelle.
Thank you.
Any other questions?
This is Mason Morrow from Channel 2. I apologize, I jumped in a little late, so if this has already been brought up, I'm sorry again. Dr. Robertson, I spoke with someone last week who visited the ER at St. Francis South and had brought up the point that she didn't believe the COVID-related patients that were being separated from all the other patients. Is that the case? Do you know that for sure?
I don't know which part of the hospital this person was
in the emergency room.
In the emergency room.
Yes.
Yeah, no, I think that to the best of their ability, they try all of the EDs probably in every hospital tries to, isolate patients, COVID patients in particular. But I would also tell you that there are times that it's not possible, where there are, patients that are in preferably negative pressure rooms that we ultimately determine are COVID positive. And so that is possible, particularly when our ERs are seeing the volumes of COVID patients that they've been seeing over the last 3 or 4 weeks. One of the things that's important, though, to that point is, a lot of folks have come to our emergency departments that had care needs that could have been better served outside of the emergency room. So for instance, we have virtual care capabilities. Believe it or not, through this technology that we're using today, there is a lot of care that can be delivered appropriately. We also have urgent cares around the region, and those urgent cares are set up to be able to handle most everything as well. So what I've been encouraging folks, friends and neighbors would be, think about using virtual care or urgent care before the emergency department, because quite often there's most of what we care for, or much of what we care for in emergency departments can be cared for in another setting. Now, granted, if you're in a serious car accident, you're going to be brought by EMS to the emergency department. That's obviously a different story. But for folks walking in, I would encourage them to look at other care options first.
Okay, thanks. And then one more thing, you also brought up ventilators a little bit ago. Where are you at right now with supply in the ICUs with ventilators?
Yeah, I think our ventilator statistic this morning, we have, about 35% of our ventilators are not being used. So we're not in a position to where we're, worried about running out of ventilator capacity. What I can tell you is that, what's unique about this wave is, and maybe it's because the average age of the patients are younger, we have more patients that have been on ventilators that are staying on ventilators longer than for longer periods of time, and it just that's a reflection of how sick their lungs get from this COVID pneumonia. So that's a challenge for us, because we're obviously our docs are trying to wean these patients off the ventilator and get them back onto either oxygen through a mask or by a nasal cannula, and then ultimately room air. And that seems to be a little bit more difficult this go around with this cohort of patients.
Okay, thank you.
Thank you.
We have time for one more question.
It's Abigail Dye with Fox 23 again, Dr. Robertson. Forgive me if this information is posted somewhere, but what percentage of the ICU is COVID-19 patients?
You know what, Lauren will have to get back to you, because I'm not sure I can give you that exact answer. So a significant, across all of our hospitals, it is a significant percentage of our ICU patients are patients that are COVID positive, but it's not 100%. We still are taking care of patients with strokes and heart attacks and trauma victims, and unfortunately those care needs are continuing, but there are a significant number of COVID positive patients that are requiring ICU levels of care. So I'll have Lauren follow up with you with the exact specific percentages. And what I'll do is then close by first thanking Michelle, thanking her for her leadership in Muskogee, and again, importantly, just to remember all of our staff, our frontline caregivers, be they nurses or respiratory techs, or our teammates that actually do things like sanitize the rooms or deliver food to folks. Every one of them is incredibly important. They're all being asked to go above and beyond, to work together as a team to care for our community members, and we recognize how important they are, and I hope you will also recognize how important they are to the folks in Eastern Oklahoma. So thanks, and we'll see you again next week. We're going to invite one of our primary care physicians to join me next week to talk a little bit about what they're seeing sort of post-COVID with folks that have longer term symptoms and issues. We thought that'd be important for you all to hear.
And as a reminder, the St. Francis COVID data dashboard is updated daily on our website at stfrancis.com/COVID-19. Also on that page is information about our online vaccine scheduling portal and information about testing and our drive-through testing site. If you have any other suggestions or ideas for guest speakers to join Dr. Robertson on these weekly calls, please reach out to us and we can try to arrange that. And again, thank you for continuing to cover this and keeping our community informed.